Hello, and welcome to the August issue of the Journal of Vascular Surgery and our video of 4 papers that are available for you to read, as well as many other excellent papers. The editor's choice article this month is entitled Regional Variation in Racial Disparities Among Patients with Peripheral Arterial Disease, written by O'Donnell and co-authors. This paper determined racial disparities in patients who underwent infrainguinal revascularization or amputation between 2003 and 2017. The authors identified over 90,000 patients, 70% of whom were Black. Black patients were younger and less likely to smoke or have coronary artery disease or chronic obstructive pulmonary disease, but they were more likely to have diabetes, limb-threatening ischemia, dialysis dependence, and hypertension. Black patients experienced significantly different, both higher and lower adjusted rates of 30-day mortality and amputation than white patients in several regions. Compared with white patients, Black patients experienced consistently lower long-term mortality, but higher rates of major adverse limb events and amputation. The authors concluded that there were significant racial disparities in outcomes in patients with PAD, with regional variation contributing to perioperative disparities, and that underperforming regions of the United States should use these data to generate quality improvement projects. The CME paper for this month is Comparing the Efficacy of Shunting Approaches and Cerebral Monitoring During Carotid Endarterectomy Using a National Database, by Whiskey and co-authors from Providence, Rhode Island and Baltimore, Maryland. They studied the practice patterns of carotid endarterectomy, including the use of shunts and cerebral monitoring techniques, which are typically surgeon-dependent. The authors divided carotid cases entered into the Vascular Quality Initiative database between 2012 and 2015 into routine shunting, selective shunting, and never shunting cohorts. The selective shunt group was subdivided into cases with awake, EEG, and stump pressure monitoring. The authors identified over 28,000 endarterectomies, of which over 14,000 involved routine shunting, over 12,000 involved selective shunting, and 1,700 involved never shunting. Of the selective shunting cases, a little over 6,000 involved EEG monitoring, 2,300 involved stump pressure monitoring, and 2,015 involved awake monitoring. In-hospital death and stroke were 0.3% and 0.8% respectively for routine shunting, and 0.2 and 0.9% for selective shunting. The in-hospital death rate was lower in the awake monitoring group than in the routine shunting group. After adjustment for patient risk factors, there was no difference in the rates of any outcomes among the groups, although there was a shorter postoperative length of stay for the awake monitoring group compared with routine shunting group. The authors concluded that there were equivalent rates of in-hospital death and stroke using different approaches to shunting and cerebral monitoring. The next paper, Treatment Outcomes in Diabetic Patients with Chronic Limb-Threatening Ischemia, by Lang and College from Beth Israel Deaconess Hospital in Boston, evaluated the perioperative outcomes after infrainguinal bypass for chronic limb-threatening ischemia in patients with diabetes between 2011 and 2014. The authors used the National Surgical Quality Improvement Program to identify patients undergoing infrainguinal revascularization with and without diabetes. In almost 9,000 patients undergoing open or endovascular treatment, patients with diabetes were younger and more often non-white, non-smokers, and obese. Patients with diabetes presented more often with tissue loss and were more likely to be treated with endovascular intervention. The authors concluded that patients with chronic limb-threatening ischemia and diabetes undergoing revascularization have a similar 30-day outcome compared with those without diabetes. Prolonged length of stay and readmission in patients with diabetes is likely secondary to other baseline comorbidities, such as higher rates of tissue loss. The concern about worse perioperative outcomes in patients with diabetes after bypass was unsubstantiated, and that should not discourage physicians from performing an open bypass on patients with diabetes. The final paper, statin therapy is associated with higher long-term but not perioperative survival after abdominal aortic aneurysm repair, by O'Donnell and other colleagues from Boston, Pittsburgh, and Rochester, Minnesota, assessed the impact of statin therapy on survival after abdominal aortic aneurysm repair. Between 2003 and 2017, the VQI database identified almost 26,000 abdominal aortic aneurysm patients, and 69% were taking a statin preoperatively. Preoperative statin therapy was not associated with a reduced 30-day death or in-hospital stroke or myocardial infarction rate. However, patients taking statins preoperatively experienced a higher adjusted 1 and 5-year survival benefit. Of the 11,900 patients not taking a statin preoperatively, 24% of them were started on a statin before discharge, and those who initiated a statin experienced a higher survival at 1 and 5 years. The greatest long-term survival difference was actually in patients with ruptured abdominal aortic aneurysms, and that was 87% versus 62%. The authors concluded that preoperative statin therapy is associated with higher long-term survival, but not reduced perioperative mortality and morbidity in patients undergoing abdominal aortic aneurysm repair, and that initiating statin therapy post-op was associated with a markedly higher survival, particularly in those with ruptured aneurysms. We hope you enjoy this month's JVS and the other outstanding articles in this issue, and thank you for your attention.